I'm David Savitz. I'm a professor of epidemiology at Brown University School of Public Health, and I am the chair of HEI's research committee. And I'm going to show you pictures here if this works as intended. Uh-oh. Oh, there we are. Oh, okay. How did I get... Oh, this is what they were saying. I'm looking at the review committee there, and you're seeing the research committee, correct? No. Well, let me see if I go back. That's better. Okay. This is the research committee. If there are members here, maybe stand just so people can find you and you can accost them and ask them why your proposals don't get funded, and they'd be happy to entertain complaints, anything you have to offer. This is the group at HEI that sort of processes the new ideas, new research initiatives sort of through the entire life cycle of developing the RFA, of screening pre-proposals and formal proposals, and continuing on through monitoring the progress. And it's a really talented team of epidemiologists and statisticians and engineers and toxicologists, all of whom I think are just technically at the top of their field, but also are inclined and very capable to integrate what they know with the rest of what the group offers. And at least we would like to believe we have a pretty good process going, and I think the remarkable products at least attest to that in part as a measure of our success. So let me turn it over to Melissa, and then thank you.
Thank you, David. Good morning, everyone. It's great to see you all here. I'm Melissa Perry. I'm Dean of the College of Public Health at George Mason University and also chair of the review committee for the HEI. Here is a picture of the members of our review committee. Could I ask the folks that are here if you could stand so you can be recognized? Yes. These are our fine review committee members and others who weren't able to attend our conference. All of the recipients, all the grantees in the room, just so you know, if you're in process and you're doing your research and you haven't gotten to the point of writing that review yet, that report, please know that this committee is so focused on ensuring that we get to disseminate as robustly and widely and accessibly as possible the research that you're doing. And HEI is known for producing fantastic reports. We saw them yesterday in a very impressive chronology and timeline of the kinds of impactful reports that HEI has produced. And so much comes through that process of rigorous review. So just to give you a preview that you'll be going through this process, and please know that it's all very, very positively intended. It's all intended to be very constructive because the review committee members really care about the years of toil that you all are involved in as researchers and want to make sure that your work is as impactful and disseminated as widely as possible. Without further ado, I am delighted to introduce our speaker for the morning. This session is entitled Spotlight on HEI Activities and Future Directions, and leading us off is Dr. Zorana Andersen from the University of Copenhagen, Denmark. She's going to be talking to us about the research that she's been leading related to long-term exposure to air pollution and COVID-19, mortality and morbidity in Denmark, the AIRCODEN study. Who is most susceptible? Dr. Andersen, take it away. Thank you.
It's not something I'm going to use.
You don't need that.
All right, good morning, and thank you very much for inviting me to speak. First time for HEI, so I'm very excited. So let's see how this works.
Just the
green one. Okay. So today I would like to talk about... nothing's happening.
So you'll see the first one is what's being displayed, and the next one is the upload.
Yes, not switching. This one, yes, sorry. Okay. So I'll tell you about the study we conducted in Denmark, and I also put it in a context of what do we know about air pollution and COVID today, so in a context of evidence we have up to date now. So the early research and idea that air pollution can be related to COVID-19 came actually already a few months into the COVID pandemic 3 years ago in April with a famous study from Harvard that was able to utilize data on a few months on COVID pandemic, linking county-level air pollution, PM2.5, to county-level mortality rates, and found a striking, strong association between PM2.5 and COVID mortality. And since this has raised the headlines worldwide, also in Denmark, we had commented on this study, but we're still waiting for individual-level studies to see really whether this holds in it with individual-level data. Now, 3 years later, we still have fairly few well-conducted individual-level studies. I was able to identify these 4. I know a number of you in the audience are also working on some reviews, and maybe you'll point out me to more. But there are these 4 studies that were able to look in general population and follow people for either incidence or hospitalization or mortality due to COVID-19, with somewhat mixed results in what they look at and what they find, but they all find association with one of the outcomes they looked at. There are many more studies that had data on COVID patients, and there's a number of studies now that looked at people that have tested positive for COVID-19 and followed them up for either hospitalization or mortality or ICU visits, and 2 studies that looked at people hospitalized with COVID and looked at mortality. Also, Mike Jarrett's study just came out, and they all find associations with at least one of the outcomes they looked at. We also, in this idea that air pollution gives this serious respiratory infection, lean on evidence that we have on pneumonia and air pollution and other lower respiratory infections in populations. We have a lot of evidence in children, but in elderly we have not so many studies. In the recent HEI report looking at incidence of pneumonia found relatively weak evidence with only 3 studies. But if we look at pneumonia mortality studies, there's actually a number of studies, 12, and out of which 11 find association. And we were recently in a lab study in Europe in pooled cohort analysis, found strong association with NO2 and black carbon and pneumonia mortality. So this also seems to provide plausibility for air pollution COVID-19 link. So in this study in Denmark, we aim to investigate whether long-term exposure to air pollution leads to increased risk of contracting COVID-19 and and developing serious COVID-19 disease leading to hospitalization or mortality. We also aim to find who is most susceptible to these effects. So we did this, we were able to conduct a nationwide study in entire Denmark. This is facilitated by the national COVID-19 surveillance system we have in Denmark that collects all data on all PCR tests in Denmark centrally and has made it available for research. And here we were able to design a cohort study of all Danish citizens age 30 and older on March 1st, 2020. And by the time we got the data, we had 14 months of COVID-19 pandemic and defined 3 outcomes. Incidence, which is defined as the first positive test for SARS-CoV-2 virus. Hospitalization, which is defined by the surveillance system, not by us. So we use their definition. This is inpatient or emergency room admission from any cause. So it's for more than 12 hours and within 40 days after the first COVID positive test. And we also define death from any cause. So it's not COVID death, any cause, which is within 30 days of the first positive test. We also looked at all-cause mortality just to compare whether association between air pollution and all-cause mortality in this period looks like something before COVID that we have recently also studied in nationwide cohort. We use 2 exposure models. We have Danish nationwide exposure model, a kilometer resolution. We have this for over 40 years now, annual means. And we use 2019 annual mean as the main exposure, as this is closest to the pandemic. We also utilized the elapsed exposure for entire Denmark that we had available as a sensitivity analysis, but this is available for the year 2010. I think you all know about elapse here. We use standard Cox regression analysis. We adjust for gender and age in the basic model and also for some administrative units that are relevant for pandemic strategies in Denmark, region and a parish, the smallest administrative unit. In model 2, we adjust for individual level socioeconomic factors that we have really good data on, also nationwide level in Denmark, education level, income, wealth, and so on. And in model 2, we adjust for area level socioeconomic data, also quite extensively at parish level, our smaller unit. In model 4, we were also able to add some kind of idea proxy for pandemic development. We were able to calculate monthly municipality COVID-19 positive rates. And this was a time-varying model then, but we chose model 3 as a main model, and I'll show you later because we don't find much difference, and time-varying model took much longer to run. We also did an additional analysis with indirect adjustment for missing lifestyle and alternative air pollution model. Comorbidities here are defined also from our nationwide registers on hospitalization for all Danish cities, and over 40, 50 years now we have data for that. So this is a record of hospitalization or medication use, also nationwide register for these major cardiovascular respiratory diseases, lung cancer, diabetes, and dementia, prior to March 1st. So results, this is the Danish COVID pandemic. We see clearly that we have these 2 waves. In these 14 months, Denmark has extensive testing, especially in the second pandemic, so define August 1st of 20 as the second pandemic and first pandemic in the first phase, where we had very little testing available in Denmark. This data, when we received them, we got data on 26 million COVID-19 tests performed in 81% of Danish population, that's 4.7 million people were tested. And we saw that 5% of the tested population tested positive at any time, or 4% of total population. When we merged them to our population of 30 years and above people, we found 140,000 cases or incident cases of COVID-19, about 11,000 hospitalization and 2,600 approximately deaths, and about 62,000 people died from all causes in this period. This is our air pollution maps, just to point out that in PM2.5 you see this influx from Central and Eastern Europe in Denmark, where NO2 and black carbon are very much traffic urban pollutants. So these are the main results. So basically we find very strong associations with all 3 outcomes. We find similar size of associations for NO2 and black carbon for all 3 outcomes. For PM2.5, we find stronger associations with mortality than with hospitalizations and incidents. We find very strong associations. You can note our units of increase. This is EQR. And we also find association with all-cause mortality that is also stronger than we saw prior to pandemic, but comparable. We see actually very strong association with all-cause mortality in Denmark in a number of other studies as well. We also found, so this is the model 3, is the main model. You see little confounding by individual factors. You see some confounding by area level factors, which perhaps is intuitive with this infectious disease outcome. We find no confounding, very little when we adjust for this pandemic development by these municipality rates. We also find almost identical results if you look at 3 and 10-year exposure window to air pollution that we had. We find mainly linear, somewhat curvilinear exposure curves. Those response curves, we see associations down to the lowest levels of exposure in Denmark, and we are low in Denmark, way below EU standards. We also find a strong and positive association with the labs, our alternative model. They're somewhat lower, but nonetheless quite consistent results, which we were quite confident about it. We're finding something, and they were a little bit smaller, as expected perhaps, since this is 2010 exposure. We also looked at different pandemic waves, and we find mainly strong association to the second pandemic wave, or pretty much results are limited to second pandemic wave. We also looked, some studies look at general population, some limit to people that are only that were tested. So we tried this as sensitivity analysis, and we find pretty much same associations when we looked into only tested individuals as the main population. In our results on effect modification, we find some novel results up to this point. We don't see much difference by gender. We see a little bit stronger results in elderly with PM2.5, but not NO2. But consistently, we see that individuals in lower socioeconomic groups those with lowest education, those unemployed, with lowest income or wealth, have highest risk of contracting COVID-19. This is incidence data, just to point out. We also see, we were able to look into number of people living in household, and we see increased risk, and the highest risk in household is 5 or more people living together, which also seems interesting with this infectious disease. We looked also at a number of these comorbidities, and we see consistently higher associations with prior cardiovascular disease and respiratory disease, especially prior influenza, as well as dementia and diabetes, and not with lung cancer. And to make this comparison to existing literature, again, I want to point out we find much stronger associations than other studies, but fairly consistent results compared to other studies. If you compare our results to other 3 studies on incidence, all but one, the Roman studies, find associations with incidence, and they all also find quite strong associations. If you note, all units are different, so it's a bit confusing, but that's the main point. There's only other studies on hospitalizations in general populations. They also find association, and 2 other studies on mortality also find association, also lower. And just to point out, this all kind of comes nicely together with early ecological study from Harvard that we find actually similar associations, strong positive association, PM2.5, even some overlap in effect estimates. And this is the point I want to raise, I think, now after looking at all existing studies and also number of ecological studies I didn't mention here, and also some more poorly designed studies. And this is, there are a number of meta-analyses. There's extremely much going on in literature in this field, and I cannot completely keep up. But one of these recent meta-analyses that made a little different approach in summarizing the evidence than I did here, and I see some of these studies are actually ecological, and there's a little mixing of pears and apples here, but nonetheless, no matter what you mix, you find consistently positive association across all literature, and very strong association. Note these are per 10 micrograms per cubic meter in PM2.5, so much stronger than all-cause mortality estimate around 8 that now we operate with. Despite different designs, I think literature is extremely consistent with this strong association. Biological mechanisms, I think they are quite well in place. We do know that plausibility of air pollution increasing risk of contracting COVID-19 is by 2 ways: indirectly by increasing risk of cardiometabolic respiratory diseases that in turn increase risk of contracting COVID-19. This is well established now. And also directly by compromising our immune system and response to infections, increasing risk that we get infections because our immune responses are compromised. There's also, and I'm not expert in reading these mechanistic papers, but there's this double hit hypothesis that is interesting that shows that both PM2.5 reduction in immune response abilities and NO2 hit on our lungs directly could give plausibility for these very strong effects that we see. Also combined with increased susceptibility of people that have prior chronic diseases, that maybe it is quite possible that we see these very strong associations. So strengths and limitations of our study. This is the first nationwide study made possible with our central collection of COVID data in Denmark. I think this is still unique and not possible elsewhere. We have large testing of population, very little selection. Every testing was offered in Denmark free of charge to everybody. We have number of sensitivity analysis, so we're quite confident in these results. Of course, we lack data on individual lifestyle, access to COVID, a number of other parameters that probably explain some of the large effects we see, but still we have one of the most well-adjusted studies with respect to socioeconomic status. We lack data on nursing homes, and there was a lot of interest whether they're more susceptible, these people living there, but we do not have that. And of course, COVID, all the issues with how we define COVID incidence, and this is depending on testing strategies, pandemic lockdown strategies, that's inherent to entire field and how we define this. And we have also differential errors, just to mention, in assessment of different groups. So maybe some of the results we see higher effects in respiratory patient, cardiovascular. That's maybe because these people were also more tested during the pandemic. We just have to take that into account. So finally, with our study and overall evidence, we find that we really have strong evidence now that long-term exposure to air pollution is associated with increased risk of both contracting SARS-CoV virus as well as developing severe COVID-19 disease that leads to hospitalization or death. We find that chronic disease patients and people in lower socioeconomic classes are more susceptible. And we really see that these findings contribute important new data to really strong new evidence that air pollution is also a risk factor for COVID-19, as well as for likely other infections. And that reduction of air pollution should be adopted in strategies dealing with current and future pandemics, as well as our infection during the winter. And finally, I just want to thank my PhD student, Jawei Zhang, who has crunched the data and provided all the nice slides for me, and the whole group that is part also of the paper that's now under revision in European Respiratory Journal. And I would like to especially thank HEI for funding. It's been an extremely interesting project to work with, and as well to my entire group. And it has been really symbolic because we are a fairly new group and Corona hit, and a lot of people that are new to group and moved to Denmark could not work in office together, and this project really provided us all together to discuss together and experience personally, and it was very nice to have this project moral support to work together, and the fact that we made it with 7 months delay in data delivery, it's been a success for the group as well. So thank you. And I'm happy to questions.
What we're going to do now is we're going to do a response. So
Yes,
there'll
I'll
be
stay
an
here.
opportunity, by all means. Dr. Andersen, thank you so much. Beautifully presented and very, very rich data. So you all know that science is very iterative. And as I mentioned, the review committee works really hard to give as much feedback and overview and perspective. And oftentimes when we're doing models, our models are only as strong as the way that we can explain them and defend them. And so we wanted to model that today by providing a response from our review committee. So our review committee member, Dr. Sara Adar from the University of Michigan, will be providing our HEI review committee response to this work. Dr. Adar.
Thank you so much. It's nice to see everyone. I will start out just by saying anything that I say that is bright, I will attribute to the rest of my committee, and if I've made any mistakes, I'll take all the blame. But I did want to just start out briefly. Let's make sure I know how to use this. Awesome. First off, I really want to congratulate the investigators on this project and really say that, Dr. Andersen made this look easy. I think many of you know that research surrounding air pollution and COVID is not easy. The data surrounding the pandemic, as you can imagine, right? We always want research quality data. In the middle of the chaos of a pandemic, those types of data are hard to come by. And so, these kinds of studies, even though she really did make it look quite simple, it is always very challenging. So along those lines, I want to say how nicely this study adds to the literature. As she pointed out, really, Denmark gives this wonderful opportunity because of the way there's free healthcare on all people with individual level data, right? Where they offered free testing for COVID-19, and they did it via PCR and had a lot of testing actually to return back to life. So this data set really provided a wonderful opportunity to study this question. So really that's fantastic. I did mean to say, if I can figure out how to go back, right? It's a huge sample. I mean, if you look at these counts with individual level information, this is a really wonderful contribution in that way. By having information on each person, right, as you saw, they're able to assess characteristics on the individual level, both for adjustment and also for that look and sensitivity. So that's really amazing. Similarly, they have address information, which means that they were able to assign, as we saw, air pollution estimates at the location level for each person. And they also did a really fantastic job, not only of considering individual level information, but also these area level metrics, which as we think about a pandemic and the way in which, it's transmitted person to person, your neighborhood matters quite a lot in these analyses. So that's a really wonderful other characteristic of this study. As we saw, right, this is just another brief summary of the data that was presented so beautifully before. We can see that there's pretty strong evidence across the board that air pollution is associated with greater illness and illness severity, with the one notable exception of ozone, right? So ozone actually looks to be good for you. Confusing, but it's not the first study that has seen such results with ozone, so I just point that out. Another thing that was really fantastic about this study, you saw it a bit in the presentation before, it also comes out beautifully in the report, is how many different sensitivity analyses were run. So it really helps you to understand the data better, really helps to identify any changes that might happen. They looked at Poisson models, they looked at 2 pollutant models, they looked at different subsets. So all these different ways really help us to understand the data better. I just wanted to point out a couple of things that I know I found particularly interesting. We saw this earlier, but to me it was quite notable that really it's area level factors that really changed the estimates most strongly. Individual level factors were not quite as dramatic. Again, this might not be that surprising given that it is an infectious disease that's transmitted person to person. But I did think that that was quite interesting. The other thing that I don't know if you showed quite as much was they restricted the data set to those people who were just tested positive with COVID-19 and then checked whether or not the association remained for hospitalizations and mortality. And it was interesting that the associations were not quite as strong there. You can see with mortality that association largely goes away. I'm not really sure if that indicates some sort of selection bias in terms of who's coming into the population, or perhaps if it's a biologic phenomenon that it's actually developing some sort of severe strain that's more important. But that was something interesting that came out. Similarly, we heard a little bit about this, but the 2 waves had really different answers, right? This one perhaps is less surprising in the sense that, that first wave, we were all quite locked down. We really didn't know what was happening yet. There was limited access to testing and availability. And so really in the second wave, I think they probably got much better capture and people were probably more out and about. And finally, I know that this was brought up as well. I did scale these, and I admit there's some chance that I've made some calculation errors because I did it at 6 in the morning. But the estimates are large. For those of us who are in air pollution, right, we're used to saying, oh, well, we have big population attributable risk, but our individual sizes are small. When you scale to 10, they are really noticeable. And we saw in other studies that you put up 2 that they're large, but I think it warrants our attention how big these are. So, with that, I just wanted to wrap up and say the key takeaways that, I think we can conclude is it does appear as if there's pretty compelling evidence that exposures to air pollution, are related to infection rates and severity. I think that there are some opportunities here to learn more in the sense that what's going on with ozone? Why is that one inversely associated? Does it make sense that these associations are as large as they are? And how do we think about the differences in the associations among those who tested positive? But overall, the review committee really congratulates you on a wonderful study and quite interesting and important to the literature. So thank you.
Thanks very much, Sarah. I think there's a great illustration of the quality of the research, which is exceptional, and then the thoughtful evaluation and interpretation by the review committee. We don't have time for questions in the session, but we're saying we do have time for questions. Okay, that wasn't on my schedule. That isn't what I signed up for. No, come on up. If we have time for a few questions for Dr. Andersen, any? I didn't mean to scare you all away, but please.
Thank you. This is a very interesting presentation. One question about this ozone result. Denmark doesn't have the highest levels of ozone, and especially in winter when the COVID waves came, in mass, especially the second one. So that is strange. I mean, the results that you have this. And second question related to it: have you made two pollutant analysis or multi-pollutant analysis? Because this might be that ozone is just expressing some reverse association with PM and NO2. Thank you.
Thanks, Mikkel. Very good question. We do not find association with ozone either in our mortality studies, in any of Danish studies, as we've done in the labs. So this is a strange thing we're seeing in most of our studies now with mortality and other outcomes. Two pollutant model doesn't explain this. We looked at that, and in that mostly we see traffic pollutants to be dominant for incidents, more so than PM2.5. For mortality, PM2.5 wins for two pollutant models. In Danish data, we had annual average, not warm season. This mistake after received data. We found out there was no time to try to work with warm season. That could be part of the answer.
So, Zorana, thank you very much for this very nice study. I have a question. Do you have any insight whether the stronger association for socioeconomic status could be also related to occupation? Because we saw in the German national cohort that especially a lot of precarious jobs were also associated with higher rates of infection.
Definitely, very good point. We did not have data on occupation, so we couldn't study, but we explained these findings that likely service workers had to go to work. They were also perhaps tested more because they had to go to work, but we think definitely that's related to low socioeconomic status, as well as prevalence of poor lifestyle that we also know is related to higher risk and smoking, and but we didn't have data. But that could be nice. In principle, we could look at it, as well as healthcare workers that a lot of studies showed. Of course, that's a testing. So we believe that's part of explanation for sure.
Chris Griffith.
Last question.
Chris Griffiths, London. I may have missed it. Apologies if I have. Can you tell us about ethnic group?
Good question. We have set out to do this. This was part of the call. Unfortunately, we do not have data on ethnicity in Denmark. We have a country of origin, which is a strange variable, where we have Western and non-Western countries, which are also strange mix defined by Denmark statistics. So we really could not answer this question, and we cannot in Denmark. This is not really registered. And when that is said, over 85% of the population is Danish, ethnically Danish born in Denmark. So we wouldn't even, it is not the best country to study that.
Okay, thanks.
Thanks.
Did you have one more?
Sure.
Final question from Jeff.
Hello? Oh, got it. Jeff Brook from University of Toronto, and maybe today I should have worn jeans and sweatshirt since today is my first day not on the research committee. So could have done something symbolic and not look so official. So my question is, now that the evidence is getting stronger and you've really contributed a lot to it, which is great to see, is what do we do with this information? Like, we know air pollution is something that needs to continue to be controlled. This is another piece of evidence on that. But as we're thinking deeply about preparing for the next pandemics and things of that nature, are there more granular pieces of advice we might be able to build into pandemic responses or making them not pandemics through this information? Like, where does it go from here?
Thanks, good question. Well, we have certainly used this information in our work in EU. As you know, we have this revision of directive where we serve the evidence, what we know on chronic disease and air pollution link. This somehow, people seem more afraid of infectious disease than chronic disease. So this really resonates that air pollution also increases risk of COVID-19. As well as other respiratory diseases, we still see a lot of people dying from pneumonia every year in winter months. So this has really added to our argument on reasons to go for a more strict EU directive and general interest in the public about air pollution health effects. So for us, I think that communication in general about health effects, the fact we find COVID has been received well, and there was a lot of interest. So perhaps, we had a nice collaboration with HEI early on. We had a webinar with EU commissioners, and we wrote a piece asking for COVID pandemic strategies to have air pollution control in their heart before we had this evidence, and turns out it's right. So we also called for future pandemic strategies and ongoing to have air pollution control as part of them. We also called for more studies on long COVID air pollution, which will be very interesting to follow up. I know Mike is struggling with some data with that. It's not so easy. Vaccination, and yeah, a couple of other issues we could look in more detail with this association.
Thank you.
Thank you.
Thank you. Next, we're going to hear from Ellen Mantus, the Director of Science at the Health Effects Institute, and talking about some of the future directions.
Good morning. So I'm going to go rather quickly through both some studies and activities that are going on in the air pollution program at HEI. Yesterday, you heard from Bob O'Keefe about the strategic plan, the 4 different areas that we are focused on. You'll hear about global health tomorrow, I think, from Pallavi Pant. So the accountability studies, these are the ones that we are looking at air quality actions and the potential outcomes and effect of those programs. We have 3 studies that are going to be wrapping up this year and entering our review and publication stage, so you'll be hopefully seeing those reports this year. One is looking at comparing student health and performance in school districts with and without a program to replace or retrofit diesel school buses. Another that's quantifying the monetized societal health benefits associated with emission reductions from major sources. And another looking at evaluating the effects of birth outcomes on policies to reduce transportation emissions in Texas. We have a number of other studies that are ongoing in this area. One that's evaluating changes in mortality associated with changes in nitrogen dioxide and PM2.5 concentrations before, during, and after COVID lockdowns. We have 2 studies going on in China right now looking at the relationship between health outcomes and changes in air pollution with their policies meant to reduce emissions, one particularly on banning coal heaters. We have another that's focusing on policies that are targeting mobile vehicles and electricity generating units, and a final one developing national fine scale and daily PM2.5 source impact exposure estimates in the United States. In the area of complex questions on air pollution mixtures, we have a number of studies that are looking at enhanced exposure assessment methods. Many of those studies will be entering review this year. You just heard about one of the COVID studies. We have other COVID studies that are looking at the relationship between health outcomes and air pollution. Many of these studies are also going to be entering review and this year as well. And we talked about 2 new studies last year that are looking at the influence of biomass burning on various health effects, and those are continuing well this year. We talked last year about these, the health effects of the exposure of low levels of air pollution. You heard about 2 of these studies yesterday. Again, the key features of these studies were very large populations, high-quality exposure assessments, and developing new and improved statistical methods. All of them underwent intensive HEI peer review. And as I said, 2 of these came out last year before the conference. And again, you heard about this from Francesca Domenici yesterday and Barbara Hoffman for the Brunecraft study in Europe. One came out right after the conference last year. This was the Canadian study by Michael Brower and his colleagues. They were estimating PM2.5 exposure over a number of decades in Canada and a large representative population. They found that long-term outdoor PM2.5 exposures as low as 2.5 micrograms per meter cubed were associated with increased risk of death. These estimates did vary by geography, and they were smaller when adjusted for ozone. So what's next for the low-level exposure folks? There are joint analyses going on to harmonize among the 3 cohorts using the same exposure model, covariates, and statistical models. There are also additional specific cohort-specific analyses that are going on. HEI staff, with input from the review panel that looked at all of these studies, are going to be doing a synthesis of the 3 studies and talking about the overall implications. So on to transport and urban health. There are several studies going on here looking at the relationship between transportation emissions, related air emissions, and health effects and the influence of that on with noise and green space and socioeconomic status. And many of those studies will be entering review this year. As you can imagine, the review committee is going to be very busy this year with many studies finishing up and entering review. We have 2 new studies in this area that are focused on non-tailpipe emissions. One is assessing short-term respiratory health effects in non-smoking adults who have asthma during and after sequential exercise in locations in London that represent different air quality. And another, the final one in that category is actually doing real-world field measurements to estimate and understand exposure to non-tailpipe versus tailpipe particulate matter. So last year, right before the conference, we released our new traffic report. You heard a briefing last year on this specific study. It's on our website, and you should download it and take a look at it if you haven't already. From that, though, we have built on the recommendations from that report and released an RFA in January of this past year. We're anticipating several studies in this area, 2 to 3 years in duration. We have already completed, the research committee has already completed the review of preliminary applications and invited several investigators to submit full applications. We hope to have funding decisions in this area in the fall. Yesterday, Bob mentioned the new environmental justice program that was coming out of the workshop that we held in the fall that he discussed yesterday. The mission for this new program, I think, is pretty straightforward but challenging. We want to facilitate, support, and fund research and projects and research translation that can advance environmental justice in historically marginalized communities. The role and functions of our new program flow from that mission statement. We want to incorporate these principles into what we're doing now. We also want to be a convener of multiple stakeholders and hopefully have us collaborate, share data and best practices and identify needs and solutions to advance environmental justice. We also want to develop tools and research mechanisms for translation that hopefully will aid in decision-making in this area. And we want to create new funding mechanisms that will help to support research in this area, recognizing that there needs to be some changes about the way we have traditionally done business. I want to invite our advisory council members to stand up at this time. I know some of them are here. We formed 2 different panels. This is one of them. So the advisory council is meant to provide us with strategic advice, establishing this new program and help us to identify the highest priorities and also identify ways to ensure that we can achieve our mission and integrate these considerations into what we do now. Thank you. And our next group that we have is our oversight panel, and I ask them just to stand up for a minute. This panel is like our many special panels that we form associated with projects at HEI. They will be helping us develop the research applications, reviewing and recommending funding for the studies for funding, and also overseeing that research. And we want to thank them very much for helping us with this new program. We're very excited and looking forward to working with everyone. The last thing I'll mention about the accountability, the EJ program is that we have are anticipating establishing 2 different types of research tracks. One is based on our accountability program that I just talked about. We hope to have our first solicitation out in this area in the summer. So in July, we're hoping to have that out. So keep your eyes out for that. The other track is more of a kind of a lot of words here, but multi-stage, community-driven, solutions-oriented research. This is going to require some adaptation of our normal way we do business. We're thinking of it as a 3-stage process. 1, to build the partnerships and strengthen partnerships. The second being specifically the research focus was likely in this first phase, thinking about focusing on cumulative impacts research, and the third phase to actually do research dissemination, translation, and continuity of the partnership. And we hope to have our first solicitation in this research track out in the fall or at latest winter of this year. So we're very excited about that. And I'll just mention one last thing. You'll hear more about our diversity, equity, and inclusion activities at HEI in a minute. But one of the things I want to highlight here is the summer research, the summer fellowship program that we've started. HEI, for the first time this year, will be awarding 7 fellowships to undergraduates. This is a fellowship that was open to people who were undergraduate students, rising juniors and seniors, who have backgrounds that are underrepresented in the environmental health sciences. The students could choose from mentors across the country. The program's being done in association with ISEE and ISES, and we are very happy and grateful for additional funding from the Borough's Welcome Fund to allow us to fund 7 fellows. One last comment about the fellowship. We weren't really sure how this all was going to work when we first started, and we did a lot of the staff really invested a lot of time doing outreach activity. We ended up with 52 applications, equally from rising juniors and seniors. They represented 30 institutions, I think 16 states, and 50% were from state schools, and they came from many different majors were applying for this. And I will say it was extraordinarily difficult choosing 7 people out of the 52 that we received. And we are hoping with this kind of response that we can grow and sustain this program in the future. And if you have any interest in helping us make that possible, please seek me out and talk to me. I feel quite strongly about this program, so would be happy to talk to anyone about it. So with that, I will invite Donna Vorhees to come up to talk about our energy program.
I'll pick it up. I don't know what this is, but it's here now. Good morning, everybody. How are you? Really happy to be here to talk about the energy program. With my slides. Oh, there they are. Oh. Shoot. Okay, well, it started. I'm really glad to talk to you about the research program. I want to go back, though, because I wanted to acknowledge the Energy Research Committee. David did an amazing job explaining what the Research Committee does at HEI for the air pollution program, and the Energy Research Program serves that same function for HEI Energy. And I would ask, most of our members are here today for the first time, and I would ask them to stand and be acknowledged. I didn't warn them, so hopefully they're at this session. No, they are. Okay. And I actually want a special thank you to our chair, George Hornberger, who has been with us every step of the way growing this program and has really been a great inspirational leader to me and to everyone else on the committee and at HEI. Okay, quick timeline. We underwent a great deal of research planning. That included literature reviews, that included stakeholder workshops. Many of you were at those workshops. I just want to take a moment to say thank you for all of your great ideas. The committee listened, and the research is now underway, being implemented also in tandem with community engagement, and I'll talk about that a little bit more in a minute. Research will wrap up with final HEI reports in 2024 and 2025. So that's the big picture. Just a minute. Oh, and sorry. And if you can't wait until the 2024-25, we're posting quarterly updates on each of the research studies on our website. Studies happening in 4 states, Colorado, New Mexico, Pennsylvania, and Texas, all designed to be as broadly relevant as possible, but these are the central locations. Bob mentioned the 5 research teams. Here they are, and they're represented at this annual conference for the first time. The investigators are here and had a great poster session last night. So if you missed it, please stop them in the hallway. They're doing great stuff. 2 teams assessing exposures related to water quality, and 3 working collaboratively as the tracer collaboration to understand exposures to air emissions and noise. A few words on the water research. It's really trying to answer 2 main questions. One is, can we predict where water contamination might arise from oil and gas development? If all goes well in an oil and gas operation, you shouldn't have water contamination. So it's really hard to study. And so one of the teams is working hard to figure out how we can predict where those problems might arise and obviously prevent them. The other research team is working very hard on figuring out, can we distinguish among sources of contamination? Those of you who have thought for more than 2 minutes about oil and gas know that it's happening in regions where there could be many other sources, and so we need to make those distinctions. And all of this research will wrap up soon. It's going to get finished this year in final reports, 2024 at the latest. Okay, the tracer collaboration, 2 components. They're modeling and they're monitoring, in addition to community engagement. The tracer model will be an emissions model combined with either a local or regional air quality model, and the goal is to predict local and regional air concentrations that can be used to assess community acute and chronic exposures. When I say local, I mean distances relevant to state regulatory setback distances, so pretty near to the operations as well as regional. The team's not starting with 0. They're starting with a model, the methane emission estimation tool that's taken decades to develop, and they're building on it by adding in additional operations and additional chemicals of concern for health. So the teams are measuring methane, but they're also measuring many other, a much longer list of chemicals of concern for health. They're monitoring today in 3 locations. I don't know how they're here and monitoring at the same time, but they are. But they're monitoring in 3 locations, and they're doing this with a cooperation from individual oil and gas companies who are providing access to sites, who are providing access to data that are going to help them assess, to the extent feasible, links between specific oil and gas processes and community exposures. All the while, the world continues. EPA's methane rule, new literature. So we're tracking all of this. The research teams are taking this into consideration to the extent they can during the research, and of course it'll be really important in the interpretation of the research when it's complete. So why are we doing all of this? What is the end game for this research, and how is it relevant to policy? So because all the teams are trying to do what hasn't happened a lot in the literature, link specific processes to exposure, this is going to help us define science-based setback distances. Many states asked us for this, and so it'll contribute to that. Know how to mitigate any exposures that pose a health concern. Assess the efficacy of specific emission reductions, whether imposed by regulation or the industry taking its own initiative to reduce emissions. Could feed directly into cumulative assessments of chemical, radiation, and noise exposures, because all are being measured. Radiation limited to the New Mexico research, because that's where radiation is a potential greatest concern. And help in assessing the biologic plausibility of findings that we've all read in the growing epidemiology literature on oil and gas. If any of this sounds interesting to you, we have some upcoming community events, a community open house in Loving, New Mexico, a community open house in Texas, and a great Shale Gas Network conference at Penn State coming up later this month, where some of the water quality research will be presented. Okay, the next phase of research, just a few words here. This is our literature hub. We keep reading the literature. It keeps growing, so that'll be part of the planning. Also just showing you a projection of, dry natural gas production from shale resources. I'm showing you this. This is a projection from the U.S. Energy Information Administration. And they look at various scenarios, but the point is it's going to continue. This is through 2050, right? So it's important that we continue with this research. And so we're thinking about how to optimize the ongoing research, expanding to other regions. We're thinking about initiating some special projects where we can take all that we're learning from our research and the research of others and provide a more holistic view of the impact on communities living in these regions, both the positive, the benefits, but also the potential negative effects. And of course, new lines of inquiry. Where should we go next? And we'll be doing this planning. We'll be reaching out to all of you using the same methods you saw us use before, and we summarized in a recent peer-reviewed publication about the stakeholder workshop process. There's one big difference, though, between the timing, when we did those workshops and what we were thinking about then and now in 2023. There's this big question, right? What's this we hear about the 10? I'm shamelessly exploiting my dogs that everybody's seeing on my computer screen. And really, when I took this photo, they were asking, when can we have our freeze-dried chicken liver? But it's a major issue that we need to think about. And obviously, renewables on the rise, right? Here's another US EIA projection. There's tons of them. This is just one. Solar and wind capacity, nuclear capacity compared to 2022 under various scenarios, but obviously on the rise, something we need to think about. Many, many other issues. I pulled out just two because they're so closely linked to the research we're doing. Enhanced geothermal, DOE promoting use of enhanced geothermal that uses many of the same technologies we're studying, like hydraulic fracturing. Regional hydrogen hubs, they can be sourced from methane. So as we go ahead with our strategic research planning, it's just getting underway. We are working in cooperation with the HEI air pollution program and global program because there is overlap among these programs. And so we're working together to really optimize each program and coordinate that research. We're going to need to ask these health-related questions as the energy transition proceeds, and that will be part of our planning, and we will want to hear from all of you. So you've heard it maybe one too many times, but I'll say it again. We want to hear from you, so thank you. And with that, I'm going to introduce Lissa McBurney. She's our Senior Science Administrator at HEI. She brings great skill and creativity to many, many things at HEI, but one of them is her work on the DEI committee. So Lissa.
Thank you. I do, just a couple, but don't pay attention to the slides. Well, do pay attention, but they may not exactly align with what I'm going to say. Thanks very much, and good morning. You just heard from Ellen about two of the exciting programs at HEI working directly to promote equity and justice in environmental health and inclusion in the environmental health sciences. I'd like to step back and give you a brief view of Health Effects Institute's overall goals to promote diversity, equity, and inclusion, and our developing work in this area. In summer 2020, many of us at HEI, like you, were reading and talking with new urgency about racial injustice, underrepresentation, and systematic discrimination. We discussed how these issues shaped our internal and outward-facing work and what could and should be done to acknowledge and address it. Let's see. A core group of staff brought structure and direction to these conversations and drafted HEI's Action to Promote Inclusion. Published in August 2020, this articulated our commitment to engage historically underrepresented groups in all aspects of our work and included three parts. One, to engage and provide a welcoming environment for underrepresented scientists. Two, to provide a safe and welcoming environment free from discrimination for all at HEI, and to take both immediate and sustained action to analyze our record, set goals for improvement, and report publicly on our process. So I'm here for that. Toward these goals, we started to develop externally focused programs like the Summer Fellowship and Environmental Justice. No slide for this, but we began to identify more diverse candidate pools for staff positions, reviews, panels, scientific committees, and the board. We sought input from these committees and our board, and we broadened our advertising and outreach for funding opportunities. Internally, HEI is a supportive and collegial workplace, but this was a time also to reflect on and deepen that. We engaged organizational development consultants who worked with an advisory group of staff and directors over 8 months to perform a needs assessment with one-on-one staff interviews and to conduct workshops and community dialogues on topics including building a shared language, bias, avoiding tokenism, and the ever-popular engaging in difficult conversations. Out of that work, we gained a capacity for open and honest dialogues on difficult issues, and that to build a more inclusive community, we must acknowledge diversity in all its forms and re-examine our habits of categorization. How are we doing? Okay. Excuse me. Let's see, so our next plan had 6 strategic areas. 1, to articulate by formalizing goals and the infrastructure for implementation. 2, to communicate DEI-informed policies and practices for internal and external communications. To learn by facilitating continuing education and open staff dialogue.
to engage our staff, communities, board, and the greater HEI community, to strengthen our infrastructure in human resources, and to be accountable by tracking, measuring, and reporting. So highlights of our work against these goals spans HEI. Projects are collaboratively led and succeed in part because they engage staff across departments and in all stages of their careers. In addition to the exciting work that you've already heard about, we've increased equity in our policies and practices in a number of ways. The science team conducts applicant webinars for all of our RFAs to make our processes as transparent as possible and support investigators new to HEI. The communications team is beginning to implement accessibility upgrades on web pages and social media, such as alt text and compatibility with text reader applications. Our human resources policies and procedures have been reviewed with an eye to equity and inclusion. Jobs are posted more widely, and materials received from applicants are anonymized prior to review. As you heard from Donna, the HEI Energy team is working on tools to define what community-engaged research means to us, to identify where and how it can factor into research directions, and how we can support that. So looking ahead, we know we are at the beginning of this work, and of course there's much more to learn even about the work that we need to do. Widening and diversifying our networks requires time and sustained effort. Incorporating a greater diversity of voices requires careful listening and reflection. Evaluating the results of our efforts requires humility. We're striving to capture the lessons we've learned and are learning, just as we encourage our investigators to include uncertainties, limitations, and discrepancies in their reports. We welcome your engagement with us on this work, and we thank you for your time.
Thanks very much. That concludes this morning's first session, and we'll take a break now and reconvene at 10 o'clock for the next one. So thank you all for your interest.